Welcome to Section 7 of Neuropathology. In this section, we'll be discussing topics related to headaches. Let's get started. Here's our overview slide. Let's begin by discussing some basic principles. Headache refers to pain due to irritation of various structures, including the dura mater, cranial nerves, and extracranial structures, most commonly the ears, eyes, and nose. In general, headaches are more common in females than males, except cluster headaches, in which males are more commonly affected. Now let's discuss cluster headache. Cluster headache is a unilateral headache that can be as short as 15 minutes or as long as 3 hours, and these headaches are often recurrent. Someone with cluster headache often has an intense periorbital pain with nasal discharge and tearing eyes. Also, the sympathetic nerve ending could be irritated, resulting in Horner syndrome, in which patients present with miosis, ptosis, and anhidrosis. Finally, these are more common in men than women. For acute treatment, 100% oxygen and sumatriptan can be used. And recall that sumatriptan is a selective serotonin receptor agonist. For prophylactic treatment, non-dihydropyridine calcium channel blockers such as verapamil can be used. Next, let's discuss migraine headache. Migraine headache is a unilateral headache that can be as short as 4 hours or as long as 72 hours. Someone with migraine headache often has a throbbing and pulsating pain with nausea and sensitivity to light and sound. For some patients, a warning symptom known as an aura may occur before or with the headache. This may include visual disturbances such as flashes of light or other disturbances such as tingling on one side of the face and difficulty speaking. Migraines are thought to be due to the irritation of the trigeminal nerve or cranial nerve 5, which is the nerve that supplies sensation to the head and the face. Activation of this nerve causes release of vasoactive neuropeptides such as serotonin and calcitonin gene-related peptide, both of which cause blood vessels in the brain to swell. For acute treatment, NSAIDs, sumatriptan, and dihydroergotamine can be used. For prophylactic treatment, lifestyle changes such as sleep, exercise, and diet are first recommended. Other prophylactic treatment options include beta blockers, amitriptyline, botulinum toxin, and anti-CGRP monoclonal antibodies. And CGRP stands for calcitonin gene-related peptide. All right, before we move on to the next topic, let's review with a quick question. A 35-year-old woman presents with a throbbing headache affecting the left side of her head. She reports that her headache is accompanied by nausea and a tingling sensation on the left side of her face. Her past medical history is unremarkable. What is the most likely cause of her headache? All right, this is a 35-year-old woman presenting with a left-sided throbbing headache along with nausea and a tingling sensation on the left side of her face. A unilateral throbbing headache with nausea and an aura is suggestive of a migraine headache. Migraine headache is due to irritation of the trigeminal nerve. Activation of the trigeminal nerve causes release of vasoactive neuropeptides, such as serotonin and calcitonin gene-related peptide. And again, these both cause blood vessels in the brain to swell. So the answer to the question is due to irritation of cranial nerve 5, or the trigeminal nerve. Next, let's discuss tension headache. Tension headache is a bilateral headache that can last from 4 to 6 hours. The pain is typically described as steady and a band-like pain, meaning the pain wraps around the head kind of like a band. These patients should not have an aura and should not be sensitive to light and sound. Acute treatment includes NSAIDs and acetaminophen. For prophylactic treatment, amitriptyline and behavioral therapy can be used. All right, the last topic we'll discuss is other causes of headache. There are many other causes of headache, such as subarachnoid hemorrhage, hydrocephalus, meningitis, trigeminal neuralgia, and giant cell temporal arteriitis. With subarachnoid hemorrhage, patients typically present with the worst headache of their life, and this is often due to rupture of a berry aneurysm. Hydrocephalus can cause headache, and this is due to ventricular dilation due to increased CSF volume. Meningitis is inflammation of the meninges due to infection, and this can also cause a severe headache. With trigeminal neuralgia, patients present with repetitive unilateral stabbing pain in the distribution of cranial nerve 5, and this is often triggered by chewing and talking. Finally, patients with giant cell arteriitis are typically elderly females, and they present with a unilateral headache due to granulomatous inflammation of the branches of the carotid artery. We cover all of these ideas in more detail in other videos, so we're not going to focus on them now, but be sure to keep these in the back of your mind as other high-yield causes of headache. All right, now that we've covered all the information, let's review with a question. A 32-year-old man presents with an excruciating right-sided periorbital pain. He reports that the headache occurs once or twice a week, often lasting about 30 minutes. During his headache episodes, he often experiences a runny nose and tearing eyes. What other symptoms could this patient experience in a future episode? A. Flashes of light. B. Sensitivity to sound. C. Drooping of the eyelid. Or D. Difficulty speaking. All right, this is a 32-year-old man presenting with an excruciating right-sided periorbital pain. The pain is recurrent in nature and lasts for 30 minutes, during which the patient experiences a runny nose and tearing eyes. These findings suggest a diagnosis of cluster headache. Recall that someone with cluster headache may also present with Horner syndrome, which causes ptosis, miosis, and anhidrosis. Therefore, ptosis, or drooping of the eyelid, is the correct answer. Recall from this slide that someone with a cluster headache may present with Horner syndrome, which is characterized by miosis, ptosis, and anhidrosis. A and D are wrong because flashes of light and difficulty speaking are part of the sensory disturbances known as aura, and this is associated with migraine headache. B is wrong because sensitivity to sound is associated again with migraine headache. So again, the correct answer is C, drooping of the eyelid. And that concludes this section.